Welcome to today's Infectious Disease ECHO. Um, Emily, do you want to start off with the
Yeah,
disclosures and housekeeping? Okay.
sure. Thank you, Brian. Hi, I'm Emily. I'm the Senior Evaluation Specialist at USET Tech. Today we are offering continuing education units where it's one unit to if you stay with us for the hour and complete the survey that I share in the chat, or you'll be redirected to it as soon as the Zoom ends. You also have 2 weeks if you need to leave early to watch it on YouTube, and you can still get credit that way. Next. Okay, and then disclosures. Emily Field, me, has a relevant financial relationship with healthwarehouse.com, Unilever, and Pfizer. All relevant financial relationships have been mitigated. And as I mentioned, in order to get your continuing education unit, you need to attend the whole activity or watch the whole activity on YouTube and complete the evaluation. You also, even if you don't want to get continuing education units, we love feedback, so please do complete the evaluation. And if you have any questions, please reach out to any of the USET staff and we can direct them to Cardia, or you can reach out directly to Cardia, and the contact is on the slide. And then, as Brian mentioned, we're being recorded. This recording will be available within the week on YouTube and will be emailed out. And please go ahead and introduce yourself in the chat.
Thank you, Emily. And I don't have any, I do have one announcement. We have a clinical training for hepatitis C, HIV and PrEP, and substance use disorder coming up on May 21st to the 23rd in Miami, Florida. If you want more information about that, I have the link right here. Let me get that link. Link is in the chat. And it's going to be a wonderful training. We have Dr. Mara presenting on HIV and Hep C with Whitney Essex, and Dr. Jessica Gregg, who's doing the substance use disorder. And Anna Garrett is going to be giving epi updates for 2 or 3 of those topics, and maybe I will be giving a presentation on one of those topics. We haven't decided yet. So let's welcome Sheena Lambert. She is the public health, director at Eastern Band of Cherokee Indians, and she will be presenting on the harm reduction services today.
Thank you for that introduction, Brian. I really appreciate it. I'm going to try my best to share my screen with you. Let me know if you can see my screen.
Starting to. Yep. You're good.
Good. All right. So yeah, good afternoon, everyone. As Brian mentioned, my name is Sheena Lambert, and I'm the Public Health Director here for the Eastern Band of Cherokee Indians Public Health and Human Service Division. I just want to take an opportunity to thank Brian and the whole USET team for giving me the opportunity to talk to you today about our harm reduction activities in our community. So thank you very much for asking me to be a part of this. Well, clicker's not working. It's like my computer froze. Well, there we go. Okay. So just to sort of give you a capture of an overview of what we'll discuss, or what I'll discuss today, I'll be talking a little bit about just harm reduction in general, reminding folks of, the definition, its core principles. Also be talking about some of the initiatives that are specific to EBCI that we're currently implementing, and then address any misconceptions of harm reduction in general. I'll talk a little bit about Hep C from a sort of a nationwide standpoint, a statewide standpoint, and then also EBCI specific. So really drilling down into those data elements. Talk about combating the opioid crisis, So again, talking a lot about some of those data elements and mortality data. And some of our challenges that we've had here. Beginning a harm reduction program, and then up until now in terms of implementation. And then I'll talk about one of our new projects that we have just implemented in the past year. It's not even been a full year, actually, which is our public health vending machines. And then I'll close it out with just talking about a vision of a Cherokee basket, which I think is really, really important for a community context. Okay, so understanding harm reduction. And for a lot of you on the call, this is probably nothing new, but just to sort of recap, it is an approach in public health aimed at reducing the negative consequences associated with certain behaviors, primarily drug use, without necessarily stopping the behavior. The goal is to improve individual and community health, safety, and well-being. This approach is pragmatic, acknowledging that while abstinence might be ideal, it is not a feasible goal for everyone. Instead, harm reduction focuses on preventing harm. A significant shift from, some of the more punitive approaches that have happened, and that focus strictly on preventing drug use itself. The principle of harm reduction is grounded in justice and human rights. It suggests that people deserve to be treated with respect and dignity, regardless of their behaviors. A lot of times our program actually is the only program that sees folks that are using. They don't seek any other health care. And so to have that window of opportunity for us is it's really a good thing. Also includes implementing practices like providing access to clean needles, offering safe consumption spaces, and supporting managed alcohol programs, which have been shown to reduce harm associated with alcohol dependency. On the right side there, it talks a little bit about the benefits of harm reduction. They are extensive and evidence-based. Firstly, it directly improves health outcomes by reducing the transmission of diseases like HIV and Hep C among people who inject drugs. And this is achieved through strategies such as needle exchange programs, where users can obtain clean syringes in exchange for used ones, reducing needle sharing. Secondly, harm reduction helps engage with underserved populations. Many individuals who engage in high-risk behaviors avoid traditional healthcare settings, like I mentioned before, due to stigma or fear of being arrested. Harm reduction services provide a non-judgmental, supportive environment that encourage individuals to seek help and information without feeling threatened. And then lastly, on the right-hand box there, there's a huge economic perspective on harm reduction. It's been shown to significantly reduce healthcare costs by preventing disease and reduce emergency interventions. Programs like ours save public health systems a considerable amount of resources. And some studies have actually shown that every dollar invested in a needle exchange program can save the healthcare system over $4 in potential medical costs. So understanding harm reduction, effective tools, and common misconceptions. So on the left there, you'll notice these are actually two of the specific projects that we do here within EBCI, Public Health and Human Services. The first one being our syringe service program, which is an actual physical location here in Cherokee that provides clean needles, syringes, naloxone, fentanyl test strips, and other supplies to prevent overdose deaths and reduce the spread of infectious diseases among people who inject drugs. This program was actually started in May of 2018. So it's a fairly newer program here. That may sound like it's been a couple years, but it's actually newer for us. So We also have a brand spanking new project that we just launched last October of 2023. And that project is called the Public Health Vending Machines. And these offer easy access to harm reduction supplies like naloxone kits and fentanyl test strips. They also have a variety of other items in the machine, which I will talk to you more robustly about later in the presentation. The right-hand side is just talking about myths about harm reduction. We hear this a lot, right? So a lot of, first and foremost, harm reduction programs does not encourage drug use. So no increase in drug use observed, provide services to those already using. We don't enable high-risk behaviors. We focus on reducing harm, not condoning the behavior. It also complements other treatment approaches, works alongside abstinence-based and other treatment modalities. And lastly, we do operate within legal framework and ensure compliance here with tribal laws and legal standards and regulations. We'll talk a little bit about hepatitis C transmission dynamics and the epidemiological insights. So just as a sort of an overview of hepatitis C, and again, for a lot of you, this is probably redundant, but hepatitis C, as a reminder, is an infection caused by a blood-borne virus leading to liver disease with a potential for both acute and chronic manifestations. The symptoms include, for acute hepatitis C infection may be asymptomatic or present with symptoms such as jaundice, fatigue, and abdominal pain. Chronic hepatitis C infection often remains asymptomatic for years, possibly leading to liver diseases like cirrhosis or liver cancer in the long term. It's actually transmitted through exposure to infectious blood, particularly those among people who share needles. The acute infections occur when symptoms develop within 6 months post-exposure. However, many cases are asymptomatic. The chronic infections, approximately 50 to 70% of individuals with acute hepatitis C infection develop chronic infection with varying risks for developing severe liver disease. And the prevention, there is no vaccine for hepatitis. Preventative strategies focus on safe injection practices and access to clean needles. Okay, so this slide just wanted to sort of visually show you why, another reason why harm reduction programs are so important. If you notice the reuse risk, so reusing syringes increases the likelihood of transmitting serious infectious like hepatitis B, C, and HIV. And needle pitting, so repeated use of needles can lead to microscopic pitting and dullness. So if you notice the visual picture on the right, there on the very top left box is a brand new needle, and then to the right of that, it depicts a needle that's used once, and then in the left bottom is a needle used twice, and then the right bottom is a needle used 6 times. And what we know is that if it can alter, like if injecting, if reusing the needle can actually alter the needle and can harbor pathogens that lead to infections, and the needle becomes dull. So increasing discomfort as well can also lead to other infections or tissue damage. So this slide's just talking about the number of reported cases of acute hepatitis C virus infection and estimated infections in the United States from 2013 to 2020. And if you notice that there is a steady incline in both. So this slide talks about the rates of reported cases of acute hepatitis C virus infection by sex in the United States from 2005 to 2020. And if you notice there, Generally, there has been a increase, a gradual increase, both in male and female, but male being even more predominant. This figure here shows rates of reported cases of acute hepatitis C virus infection by race and ethnicity in the United States from 2005 to 2020. And again, while acute HCV infections of American Indian and Alaska Native have gone down, you notice there's it kind of like it goes up steadily until about 2012, and it kind of goes back down and goes back up and down again. So between 2019 and 2020, it looks like it has declined. However, American Indian and Alaska Natives still have the highest rate in the United States. And COVID most likely played a role in the lower numbers in 2020. This figure here shows the number of newly reported chronic hepatitis C virus infection cases by sex and age in the United States. And if you notice on the very bottom part in terms of age, across the board, millennials and baby boomers have the highest number of chronic hepatitis C. And millennials more so, their cases are due to drug use, and whereas baby boomers, unsafe syringe practices during their childhood. So this is diving in further specifically into the North Carolina state data. So the decline in acute hepatitis C reflects overall decreases in testing during 2020. So, and if you notice, the table here just shows the North Carolina rates versus the US overall. There were 100 newly diagnosed acute hepatitis C cases in 2021. And between 75 to 85% of acute infections will progress to a chronic infection. So that North Carolina rate is still high. Again, this is diving into further North Carolina data here. The North Carolina state data from North Carolina DHHS. Injection drug use is a growing risk factor for hepatitis C. And injection drug use was reported by 53% of people diagnosed with acute hepatitis C, which is that gray line in the chart that you see on the slide there. North Carolina, again, this is North Carolina state data. Currently, acute and chronic HCV affected different age groups. So this shows the acute HCV and how younger populations are affected most by it. This slide shows, actually figure 9 on the left there shows the acute hepatitis C rates in North Carolina by county of residents at diagnosis in 2021. And the Eastern Band of Cherokee Indians is located in those 5 western North Carolina counties. So we do have some items there in blue, and we also have some darker purple areas. For figure 10, the diagnosed chronic hepatitis C rates in North Carolina by county of residents at diagnosis in 2021. If you notice, and can you guys see my cursor right here? So this is Swain, Jackson counties. Those are high in terms of chronic hepatitis C. Hope that's helpful. We do have counties here too. This map here is vulnerable counties and jurisdictions experiencing or at risk of outbreaks. And all of EBCI tribal lands right here are located in CDC's experiencing or at risk of breakout locations, We do have land in 2 counties, Graham County and Cherokee County, that are on CDC's top 220 vulnerable counties for rapid dissemination of HCV infectious among people who inject drugs. I really like this map. I think it provides a really great visual, and it is provided by the CDC. So in talking about drug overdose mortality, so this is, again, this is another map that just shows the in 2003 drug overdose deaths per 100,000. And if you can see, the darker areas are some of those that are higher risk, and that is us on the map. Drug overdose mortality. Oh, my computers. These are deaths. Did I go back one? There we go. There we go. So this slide is age-adjusted rate of drug overdose deaths by race. And if you notice that the American Indian Alaska Native numbers are in 2020 42.5, and then in 2021 56.6. This shows the overdose deaths demographic snapshot. So in North Carolina in 2020, American Indians, Alaska Natives had the highest rate of overdose deaths, almost 2.5 times the rate of the next highest group. North Carolina state data from North Carolina Department of Health and Human Services. So this graphic illustrates substance use health burdens in North Carolina when examining the rate per 100,000 people. American Indian communities are particularly hit hard. So now I'm gonna talk a little bit about the data. What is our data here within the EBCI? What's it telling us about substance use issues? So in looking at population health data, we note that about 6.8% of Cherokee and Hospital Authority's EBCI population have ever been diagnosed with hepatitis C. 2.5% of the EBCI population with hepatitis C currently have high viral loads, and over half of the EBCI population with hepatitis C are between the ages of 25 and 39, which is, again, that's that millennial age group. Oh, I skipped one. So this slide here is EBCI living population ever diagnosed with hepatitis C. Again, the ages that are hit hard, which actually really reflect the national level statistics, is the millennials and baby boomer generation. This slide here is specific to those here that have ever been diagnosed with hepatitis C by sex. And both are high, and some are even close to being equal, but females have higher rates of hepatitis C in the community generally. Okay, so this slide is actually depicting a visualization of our overdose data collection. We actually started using this around the time that we started our syringe service program. It is it's called ODMAP, and which stands for Overdose Detection Mapping Application Program. And this we actually heard about this program from the CDC, and started using it, and got the tribal EMS on board to start tracking real-time data. And on the left, you'll see the bar chart that shows the number of suspected overdoses per month. which we are very glad to see a dramatic decline in suspected overdoses in the past year. If you can notate that. And then on the right there, you'll see the locations where the overdoses actually took place. Each suspected overdose is represented by the circular dots on the screen. The suspected overdoses are marked by a triangle. And naloxone administration data is also collected. So for example, we know how many times naloxone was given, and if it was a reversal or not. So I think that's really important. Again, this program was actually created by the Washington-Baltimore high-density drug trafficking area. And its purpose was to provide real-time data on overdose incidents across the country. Law enforcement, public health officials, and first responders like our EMS use ODMAP to gain insights into overdose trends. This has been a game changer for EBCI. And one thing that I do want to share about this technology is that it was 100% free. Anybody can sign up to do it in any community. So incredibly helpful. It also allows us to identify hotspots in the community where there are a lot of overdoses or concentrated amounts of overdoses. We can also identify tracking spikes. So we can reveal sudden increases in overdose in particular areas, for example, which might signal the emergence of a dangerous substance or batch of drugs. And then lastly, our evaluation strategy. So this has helped us tremendously with our tribal health improvement plan, which one of our priority areas is substance use. And so we're actually able to look at this table and see, are we really making impacts in these activities that we're trying to do? So for us to see this right here is incredibly, it makes us very happy because the work that we're doing is really impacting people. So I did want to share that with the group. Okay, so lastly, I want to talk a little bit about our newest project, which is our public health vending machines. So a little background, a few years ago, we actually read some research articles that focused on public health vending machines that had tremendous success and even harm reduction vending machines. This concept is a new emerging public health strategy, and we wanted to pilot this idea here in the community. Before we started the project, we wanted to ensure that the community liked the idea and it was well received, which it was. I give a few presentations to community club council and clubs individually to sort of talk about the idea and get their feedback on if indeed they wanted this in the community, which all of them did, thankfully. But again, in my presentation, I shared why we wanted to do this project, and we wanted to expand access to health and wellness supplies for all EBCI community members by providing 24/7 access to these machines. We wanted to reduce barriers to access health and wellness supplies. It costs $0 for tribal members to utilize these machines, and it just aligned with our public health initiatives of health promotion, disease prevention, and of course, protecting the community. We have 10 public health vending machines here on the boundary, and there's actually one in every single community, which is wonderful. Here's a map of where they're actually located. And this is an actual depiction of the products that are in the machine. We actually have 28 different health and wellness supplies that we offer in the machine, and toiletries, anything from toiletries, deodorant, dental kit, shampoo and conditioner, body wash, personal care products such as hand sanitizer, lip balm, sunscreen, lotion, insect repellent, tampons, maxi pads, reproductive health products, such as condoms and pregnancy tests. We also have medical supplies such as first aid kits, ibuprofen, Tylenol, Benadryl, anti-acid, anti-itch cream. And then, of course, overdose prevention supplies like nasal naloxone spray and fentanyl test strips. We also have baby products and personal protective equipment such as COVID-19 test kits and face masks, and 2 little slots there for bottled water. So I really am excited to share the data here because this is we actually launched the vending machine project as I mentioned earlier in October of 2023. And the vending machines do have a software component to them, which we were really thrilled about, because we want to make sure that people are better off, and that we're really truly providing supplies and things that the community really need. So here is an actual dashboard for the vending machine project. And this particular report was ran 4/8 of 24. So this was April 8th. So it's almost like a month ago. And on the very top right hand is the total number of products that we have dispensed since October of 2023. Right here in the quantity dispensed by hour, this is just the time of the day that they're used most. We can actually see when they're used the most often. So generally across all 10, the vending machines are used mostly around 6 p.m. in the evening time. But I think what's important to note is that they're used all the time, 24/7, even at nighttime. And that was really critical for us. We have a list here of, in terms of our 10 that are labeled, in terms of most popular or most used, quantity dispensed by location. Our number 1 vending machine is Food Line, and that's not surprising given its location. This is the only grocery store that is here in Cherokee, and a lot of foot traffic in this area, and so that's not surprising. Birdtown being the second, Yellow Hill third. We have one at the Call Boundary Head Start and Early Head Start, Big Cove, PHHS Admin, and so on and so forth. We're also able to show what items are dispensed most by product, which you see here. And the dental kits are very popular, both for adults and child. But it's really interesting. This is an aggregate depiction of all 10, but we do have the capability to drill down into data just per vending machine, which can look quite different. And in the right-hand corner here is the days of the week. So distributed by day of the week, we can tell what day of the week is the busiest, for example. And for all 10, generally Saturday's the busiest, which is not surprising either, right? And then Narcan. So again, this is how much Narcan has been dispensed overall. And this is how much, this is per each machine. So, 178 at Food Line, 64 at Birdtown. So that's quite a bit of Narcan that's been, and again, this is in addition to the syringe service program that we have, that we also give Narcan out to. So this slide is just a depiction. We wanted to do some customized marketing on our vending machines. And one of the things that was really important to us up front was the planning for these machines. And we worked with the company to set up, and our tribal enrollment office to set up, to be able to put all enrolled members into the vending machine up front. So there's no process you don't have to fill a form out and get an access card. We wanted to eliminate all of those, right? It's all about getting it fast and quickly. So we did that all up front. And so as soon as the machines were set, folks in the community could actually start using the machines. And this is just instruction sort of depicting how to type their enrollment number in, and how they activate the utilization of the machine. I will say this, that some items do have daily, weekly, and monthly limitations. Narcan and fentanyl's test strips are definitely not, they have no limitations because they save lives. But some of the others can be more restrictive. For example, deodorant is usually once a week because that's about what you need. You just need one deodorant a week, right? And toothbrushes, toothpaste kits, stuff like that. And if we didn't have those limitations for the vending machine, folks could come up and clean the whole machine out. And we didn't want that to happen, which kind of defeats the purpose of the project, right? To make sure that we take enough individually and save some for other community members. So the benefits of the vending machine project was, of course, accessibility. You know, they've been placed in convenient locations, extending the reach of public health services beyond traditional clinic hours. This is especially helpful for people who may struggle to get appointments due to work schedules, transportation issues, or stigma. We wanted to reduce harm, providing essential harm reduction supplies like nasal naloxone, and of course fentanyl test strips. We wanted to improve public health, so stocking health supplies such as condoms, pregnancy tests, and first aid kits. Promote sexual health, prevent the spread of sexually transmitted infections, and encourage basic wound care. And I think that fourth bullet point is a really big one for us, the discreet access. So the vending machines offer a stigma-free way for people to access sensitive healthcare products. This can be particularly important for those who may be uncomfortable approaching a healthcare provider directly. So, for example, a teen that is sexually active and may need a condom, for example. It can also help with social determinants of health. Maybe a mother who is struggling to make ends meet, getting a diaper for her infant out of the machine is helpful. And then lastly, as you've seen in the prior slides, these vending machines provide a huge data collection element. We're able to track the inventory and usage patterns because we have that software. We know when items have expired, when they need replaced, if an item is running low, when it needs to be restocked. And then also the data, what is it telling us, right? So it's valuable for us as public health professionals and understanding community needs and strategically allocating resources where they're best needed. I had to share a picture of the staff. Without these folks, the vending machine project would not work at all. They are the brains and the workhorses behind this project. So a shout out to Zollighy Public Health staff for ensuring the machines are stocked, expiration dates are tracked, and the software is kept updated. Also, thank you to the public health team for planning and tracking the utilization rates of the machine. And lastly, I just want to sort of wrap up the presentation and talk to you a little bit about our culture. And culture is a vital part of who we are as Cherokee people. And as you're seeing there on the screen, I think it's important to understand that cultural practices may be described differently. So for us to think of weaving a stronger community, more specifically, a Cherokee basket approach to harm reduction. And I want to talk a little bit about what that means. So imagine a beautiful Cherokee basket, meticulously handcrafted with interwoven reeds. Each strong yet supple reed represents an element of harm reduction in our community's fight against substance use. Just as the basket provides support and structure, harm reduction strategies work to contain and minimize the potential harms associated with substance use. So the foundation of the basket, the sturdy base of the basket, symbolizes our unwavering commitment to prevention. Educational support programs, positive youth development initiatives, and access to mental health services from the groundwork, preventing individuals from needing harm reduction strategies in the first place. The supportive weave, so the interwoven reeds that you're seeing represent the various harm reduction strategies available. These might include syringe service programs, naloxone distribution, medication assistant therapy, which is at the hospital, and overdose prevention education, vending machines. Each strategy, like each reed, plays a vital role in supporting individuals and preventing further harm. Containment and protection. So the basket's tight weave keeps its contents safe and secure. Similarly, harm reduction strategies aim to contain the risk associated with substance use. By providing sterile needles and promoting safe practices, we can prevent the spread of infectious diseases. By equipping individuals with naloxone, we empower them to intervene during an overdose emergency. So just as a Cherokee basket is more than the sum of its parts, harm reduction is just one thread in the tapestry of our community's response. It works best when interwoven with prevention efforts, treatment options, and strong social supports. So the whole basket as a whole represents resilience together and embodies the strength of resilience of our community. So providing prevention with harm reduction strategies, we can weave a stronger, more supportive environment for all, fostering healing and a path towards a healthier future. I did want to provide some additional information, some links that we actually looked at in the event that you're interested in looking at those for the vending machine project. And that is all I have. Shki.
Thank you, Sheena. That's a great presentation. Does anybody have any questions, Dr. Mira?
Yes. So first, that was a great presentation, very thorough and comprehensive, and congratulations for all that great work you're doing there. So one question I have is regarding the vending machines, and maybe I missed this part and you mentioned it. For you to access the vending machine, you still have to do a face-to-face with someone, and then you get a pass or a code or something to go to the vending machine, or you can just go to the vending machine out of the blue?
So if you're an enrolled member, you can go to the vending machine. There's no application process at all.
Okay, so that's why I wanted to ask you, because, and I know it's better getting needles and all the other supplies that you provide than the option of not getting them at all. That's definitely a better option. But the only thing we're losing with the vending machine is that engagement into the healthcare system. Then, when you have a face-to-face with someone, let's say you go to your harm reduction site and you meet a person, and they can try to engage you like you guys do, in other services. And I think you lose that with the vending machine. But like I said, I'd rather have them have the vending machine if that's what they're going to have at all. But I think we need to think of other ways of, trying to get those vending machine customers into the healthcare system. I think that's the next step or something, or maybe you already thought about that. Just wanted to ask you for your comments.
Yeah, I appreciate that. And, you're totally right. I totally agree with that comment. The education behind each product's very important. That's a core of public health, as well. And we definitely value that. And I think I will say this, that if you notice, we do not have syringes in those vending machines for a reason. because we want there was a couple reasons. One of the things is we did not want to lose that connection, especially with those that are using our syringe service program, right? And so they're still having to come in and to get their clean needles, which is really important. And so they're actually having, face-to-face interactions with those peer support specialists, syringe service program specialists. And which is very important. Just having that relationship with that patient. A lot of times, and you all know this, that's the only face in terms of programs and services that they seek. That's the only program they seek. And so they're not getting basic health care and all of the other wraparound services. And so that was one of the reasons we did not include syringes in our vending machine. Another reason was that we have a very high return rate for our syringe service program, upwards to like 96%. So we want to ensure that we are doing our due diligence and ensuring that we are keeping the community clean as well. And keeping those that do use the program accountable to bring those back.
Thank you. No, I misunderstood. I thought you had syringes in the vending machines. Thank you.
Yeah, no problem.
I had one question. Have y'all looked at the ODMAP statistics on how many doses of Narcan is typically used?
We can see that, and we can actually run reports on those things. It's always interesting. We have never done that, but that's definitely something that we could do.
Yeah, it just would seem interesting if there's a trend of like 2 or 3 doses to have a reversal. So
Yeah.
I would just be interested. That would just be me being a data nerd. So
Yeah, and I that's a good question. I wonder, like, nationally, what's the average? That's not something I've ever looked into. So that's definitely something we could definitely pull though, in the future and take a look at more.
I know there's a tribal nation, I can't remember which one it was, but they actually can almost tell what strain it is based on how many doses too. So like if they're seeing a trend of like this is taking 3 to 4 doses, they can kind of like interact with those people to kind of figure out where their source is. So that may be something to explore too, and looking at the dosages.
Awesome. It's cool.
does anybody have any other questions? Okay. Don't forget to thank you, Sheena. I really appreciate it. Don't forget to fill out the survey in the chat box right now. And I do have another announcement. We are not going to be having an infectious disease echo next month in June or in August because we have meetings that we're attending in June and then the Tribal Best Practices Conference in August. So we will be having those meetings instead. So y'all are more than welcome to attend those. And I don't have anything further. Anybody else? Anna? Okay. Well, you all have a great day. Thank you again, Sheena.
Thank you for the opportunity. I really appreciate it.
Of course.